Today's lineup is going to be kicked off by Dr. Christy Henderson. She's our keynote speaker this morning. Christy is a VP of Patient Access and Health Transformation at Ascension Health and is also a clinical professor in population health at University of Texas, Austin. It used to be. She's also led the development of a nationally recognized telehealth program. So please give a loud round of applause.
Good morning. So what I know is that if some of you decide to change careers, you could always get one in dancing after what I saw last night. So we will leave those stories here, right? But I had a lot of fun last night, so thanks for having me. So I'm going to kind of give you a glimpse into what I think about when I think about how we change the healthcare system. And we all know that the system is extremely fragmented. It's too expensive. Patients hate it. We hate to take our family members there, and we have to do something different. So this is a map that I want you all to memorize. And this is a real one. So for those that work for my health system, don't tell anybody I showed this. But the green little sphere things are actually where there's a different documentation, communication system where they don't interface with another system. So as a patient is going in our hospital, in our ER, and going through the system, there's a lot of dead ends, and there's a lot of silos of information where the journey is not good. And so we all know that challenge exists, and we've all been trying to tackle that for quite some time. In contrast to the patient journey, I'll show you a little video of a passenger journey, and I'll cue this up. So if you think about air traffic control and think about what happens across the country and across the world on a daily basis, let me give you some numbers. 42,000 flights are going through the air every single day, 2.5 million passengers, over 29 million square miles in the airspace. And it's actually looks like art. They don't run into each other. The communication is all occurring out of about 521 air traffic control centers to be able to make that happen. And while we all have some delays and stories that you can tell, if you put that in contrast with the US healthcare system, we have 5,534 hospitals, and we have about 35 million annual admissions a year, which is about 100,000 patients a day. So it's actually less than what is being managed in air traffic control from just 521 air traffic control towers. But if you think about it, in healthcare, we can't get people through the system. We can't get them access to clinics. We can't get them referrals. People are waiting. They don't know what to expect. They're scared. And we have all this information, but we aren't using it appropriately to make healthcare system work like that. So if you then also go over into the logistics environment with Amazon, then they're shipping 1.6 million packages a day out of about 75 distribution centers. Why can't we do this in healthcare and we treat passengers and packages better than we do our own patients? So I think that's just beautiful to look at. And I think about why we can't do this better in healthcare. And so I'll switch back to my presentation now, but I really think it's about three main things, which is we've got to change the culture, and we have to coordinate and have better communication. And so this whole journey that I've been on over the last really 20 years to redesign healthcare has culminated into what we've built in Austin, Texas, which we're currently calling the Good Health Center. But it's a whole effort to orchestrate healthcare, almost like logistics, whether that's air or packages. Why can't we use data points and coordinate and orchestrate it so that the experience for our patients and our clinicians is better? And I think we have everything we need to do that. We've just got to dig in. It's a huge, complex maze. But the center here is really built to be a frictionless system where we've pulled together care management, scheduling, all the access points, call centers, and virtual care under one roof to work together. So I'll tell you more about that. But when you think about the distribution centers from Amazon or the air traffic control from the air industry, when we look at our footprint across Ascension and where we're distributed, we're building 3 hubs to be able to navigate and coordinate all of that care. So we can pull up higher, the 30,000 foot, and look and say, where do I have access to the care that this individual needs, and how do I get it where they need it, when they need it, at the right level of service. And so Austin was the first center that opened, and I'll show you a little bit more about that in a minute. Indianapolis opened last month, and then we'll have our 3rd center in Nashville hopefully by next year. So some exciting things in those spaces, but if you think about Ascension as an organization and the footprint where we are in 22 states and DC, about 160 hospitals, and then start thinking about the numbers of providers and discharges and admissions, we have to figure out how to do this better. We've got to treat it like logistics and start using our resources smarter to be able to serve the patients that we serve in a better way. So if you think about what I mentioned at the beginning about creating a frictionless department or division to be able to really make healthcare seamless, when I came and joined Ascension now about 3 years ago, I came to actually bring virtual care. And the whole point was to say, we need to be able to bring healthcare to people instead of people having to go get that care. Well, I said, okay, I'll do that. I can do that. But it's not going to work if we don't do it different. And that means we needed to bring that into the healthcare system at the point of access. So you'll see all these different circles on this screen, and I'm going to highlight just a few things. And when I talk about integrating it into the system and access, we really wanted to have a one-call center where if you called in for an appointment for you, for your child, for your parent, that we could actually determine what was the most convenient and easiest way for you to get that care, never sacrificing quality. So if you called in for an appointment for your child who had an earache, I might say, oh, are they at school right now? Well, your school nurse is connected to our health system, and we can have a pediatrician see them over telemedicine right there, and you can join that video visit from your workplace or your home so that we can take care of that right now. That's what I meant by integration. So how do you really take brick and mortar traditional clinics, virtual care, call centers, triage centers, all these different entities that are working separately, and have them all orchestrated and working together on the behalf of the patients. So in our one call access area, this is all of our call centers. This is our nurse triage, pharmacy call centers, and we're in a journey, so we're not done with this. So we've slowly been centralizing scheduling so that in this building, the Good Health Center that you saw a picture of, when you call in for an appointment, what I described actually happens. We're scheduling appointments for the clinics, but we're scheduling virtual care. Our triage staff is right there as well, so that if you call in with a symptom or a need and need to be navigated, we have lots of options. It's more tools in our toolbox to be able to serve you. So that's the access side. Well, next to that is our whole team that are providing some hospital support services. And so one of the things we found out as well is as all the organizations are getting leaner and leaner, and our productivity measures are harder and harder to reach, but our patients are sicker, we've got to think about how do we create a safety net and bring remote workers into this so that they can actually support the bedside staff as well as the needs of the clinicians. And so this is where we centralized telemetry. We centralized what we call our e-sitter program, looking for fall prevention and making sure patients don't harm themselves. This is also all of our hospital operators, our transfer center, and our bed placement center. So I mentioned in the access center, you really can't get an appointment into one of our clinics or imaging centers without coming through us. You actually can't get a bed in the hospital or get transferred to our hospital without coming through us as well. And meanwhile, we are able to then also have this clinical surveillance team be able to monitor data points and be an extension of the healthcare team in the hospital. So I'll tell you some more about that too in a minute. When you think about virtual care, I've mentioned a couple of examples in the outpatient scenario, but if you think about in the hospital, we're shipping patients all over the place to get access to specialists. And those delays in transferring them to see a neurologist for a potential stroke or a cardiologist or a dermatologist or whoever it may be are delays in care that could result in worse outcomes, not to mention an extremely high cost shipping patients around and pulling them out of their community and where their family support is as well. So it's a stress on the patients. So when a hospital calls to transfer a patient now, I can insert virtual care and say, leave the patient there, I'll have the teleconsult done, and that specialist will see the patient through telemedicine, and they can stay in that distant hospital. Good for that hospital, good for our hospital, good for the patient. When we think about care management, there are so many different teams, well-intended, trying to navigate and do care management for patients. Insurance companies, physician offices, the hospitals, the list goes on and on and on. Oftentimes by disease state, we have care teams like heart failure teams or diabetes teams, and anybody with this diagnosis who leaves the hospital has somebody calling them. Well, usually the patient leaves and 6 of us are calling them to try to help them, and all telling them something different, and it's costly, it's confusing, and it's frustrating, and it ends up with no outcome that we want. So we've brought these teams together and said, hey, here's our strategy for care management. You're all gonna work together. And so that first chart that I showed you with the green bubbles everywhere that just had fragmented dead ends of communication, now we've brought those teams together. And while we don't have everything interfaced, and no, we're not on one EMR, we're having to make our teams look in multiple different applications and be aware of what's going on and do handoffs so that one person's the quarterback instead of 6 people. And then education is woven through all of this. How do we make sure we empower patients to take care of themselves, empower the family to support them, and educate them to be healthier? So some exciting work that's going on. So the clinical surveillance, clinical communication, and virtual care or telemedicine in our hospital are the 3 main components of the arm of work that I would describe as our hospital support services, all happening from that one center in either Indianapolis or in Austin. And I will throw in that those centers right now are still serving a market, and we're slowly expanding the region of where they'll serve other markets across the US as well. When you think about the clinical surveillance unit, I mentioned the e-sitter program, and many of you probably have those as well. But let me give you a little context of what the real challenge is here. Across our organization, we spend $25 million a year on sitters. And that number's just growing, and the need is increasing. And as behavioral health challenges are getting even tougher and more prevalent, the number is going to keep climbing. And we can't keep having the dollar figure going up. We won't be able to sustain it. Every hospital is working on a very thin margin. That's a national challenge that we all have. So we've got costs that are climbing, so we have to think about how technology can help us keep people safe, but not have to increase the cost. So we are using this to be able to change that. We still need face-to-face, one-on-one sitters for certain patients, but we're increasing the use of our e-sitter program. Our centralized telemetry unit, for those that have been involved with those, typically there's monitor techs that are sitting in different units or closets or wherever all over your hospital. By pulling them together, you can load bear the work and have more standardization of the operations and reduce variability in that service. So we've actually had better outcomes with monitoring telemetry patients now that we've centralized that. But this is really what you would, if you think about moving this forward and down just a few years, this is really a clinical surveillance unit. So I'm monitoring data points out of an EMR. I'm monitoring cameras for fall risk. I'm monitoring heart rhythms for arrhythmias. I'm monitoring information out of pharmacy lab. I can monitor when it's time for a mattress to be, flipped. I can monitor an IV pump. Anything in a system we can monitor. And right now we're putting that on the burden of a lot of different people in a hospital that are also trying to take care of patients. So by pulling that out and doing that remotely, we're able to really help the clinical team, but more importantly, ensure quality and safety that's so important while doing it in a fiscally responsible way. Another program that I'll highlight is our e-pharmacy program, and through this you're going to start seeing some statistics that I'll throw in because we're really trying to make this a data-driven program that has outcomes, that's not just about saying I've put a call center up and I've answered so many phone calls, but am I really moving the needle on health? And am I really making an impact on the cost in the system? So the e-pharmacy program was an initiative that we started where before we had nurses doing the medication histories on every admission that came in, and then the physicians would do a med reconciliation to make sure the medicines they were actually taken were actually the ones that were documented in the chart. And I'll just tell you that there's a huge gap in accuracy in there, and one of our #1 problems in a hospital is medication errors. And that's from duplication of medicines, inaccurate medicines being listed, or in many cases, just incomplete records. And so we started growing this program because we were realizing, even though we'd say, you've got to do this on admitted patients, it's important, the time, just wasn't enough time and people weren't getting to it. So patients were getting admitted with incomplete histories, and this is nationally, everyone has this challenge, but physicians were writing orders based on inaccurate information, and so we were having a lot of trouble with that. And so if you, when we took a look at this, after we started the program, I'll summarize this slide to say that in the patient population that did not have an e-pharmacy program where we were reviewing the medications, we were finding a huge error rate, over 3 medication errors on every single patient that was admitted out of our ED. So that meant that there was either a missing medication or an incorrect dose or something like that. And decisions, clinical decisions were being made on this information. But what was even scarier was how many of these medication errors were actually high-risk drugs. There's a classification of a list of meds that are considered high risk. And in those, we went and did a deeper dive, and you'll see that on the right there as well, that the errors were just as prevalent, and we were having those same greater than 3 errors per chart. And so we're going to continue to expand that and grow that program, because the reality is we can't tuck our head and ignore that the staff in the hospital doesn't have time to do a medication history, a good thorough med history. And for those that don't know how complicated it is, people will just dump out a bag of medicine and our names don't match, you can't read the sticker, or they'll tell you they take the blue pill. So that means you have to make lots of phone calls, call pharmacies, and get that history correct. So another creative way to do that. So that's hospital services. That's one of the groups of teams that are working in that center. The next one I mentioned was that one-call access. And so the neat part about this was we were really focused on experience and engagement. And how do we make sure that it truly is one call and you're not transferred, or somebody doesn't say the nurse will call you after 5, or all those things that every one of us live with every single day. But how do we maintain that experience, get customer loyalty, because it's a preferred provider, and then how do I make sure I do that in an efficient way? So we've done a lot of different things by centralizing these teams, but one program I'll highlight is around our post-discharge calls program. So a lot of people are doing this. When people leave a hospital, there's a high likelihood that they don't remember anything you told them, don't know where to go, and aren't going to follow up with their follow-up appointments, which are critically important. There's a 4-time higher risk of readmission if a patient isn't seen within 7 days of a discharge of a hospitalization. And so we started having the nurses on the units call all the patients when they left, which was great. The problem was that in our system, we had about 7.5% of those patients that needed something that was going to take time. They needed a social worker. They needed somebody to help with transportation. They needed insurance to be able to even go get their follow-up appointment. And a large percentage of the questions were about medications. And so we transferred all of that work over to our center, so that once we call them after they leave, just like normal, just checking on you, is everything okay after you've left the hospital? Do you have any needs? Do you have a follow-up appointment? Do you have your medicines? And anybody that said, I need something, or there was a problem, comes to our team and we manage that. And again, because they're coming to our center and the scheduling is handled there, the navigation is handled there, all the teams are right there and they can actually resolve these issues and help them through all those complex issues. So this was a breakdown of what all the needs were, but it's really important to recognize that our system is failing patients when they leave the hospital. Doesn't mean we didn't tell them, we gave them pieces of paper, but they didn't understand it and they need more help. So those are handled by us. Well, so what? So did that actually make any difference? So this is a screen where we actually looked at HCAHPS scores before and after this program. And across the board, on the low end, we had an increase of 19% improvement in our HCAHPS, all the way up to almost 90% improvement by just doing these phone calls and having our teams navigate through all the problems with them. So it's definitely been very beneficial. When we switch over from the access and hospital services now to virtual care, this is an area I'm probably the most excited about. I've been working in virtual care now since almost 20 years, so a long time before anybody was doing virtual care. I was putting box TVs in hospitals with T1 lines running point to point, not kidding. And it would run down the hallway with duct tape over it to the one port in the hospital. Some of you are shaking your heads, and it worked. It really did work. I'm still shocked. So I'm excited about where technology has come, where policy has come, and the readiness of all of us in health systems in our different roles to adopt technology in a different way to deliver care. And so I'm going to talk about 3 different areas just briefly of what we're doing. All things you've heard of, but the scale and magnitude of what we can do through Ascension is pretty exciting. So, and I'll tell you too that we're in a transition point. We've been piloting telemedicine for about 4 years and have now said, okay, this makes good sense. Let's move it over into the health arm of the operation and really adopt virtual care. So if you look last year to what we were doing, I'm not proud of these numbers, and I put this up here now because next year I'll have to show you how we've quadrupled them. So we have 20 specialties being delivered over telemedicine, and I'll show you what some of those are in just a minute. Urgent care, on-demand urgent care services through an app or through a desktop web portal. We did just over 5,000 visits. Our telepharmacy program is live at the Texas market and did just under 25,000. And then you start looking at remote monitoring, which is one of my favorite programs. We have 800 patients on average per month enrolled in that, and I'll highlight the details of that. It's probably one of the most impactful programs that I've ever worked with, and one of the ones that most people are the most skeptical about. So I'm just going to continue to do it while everybody's thinking it's not working, and it's working. So it's really going to be exciting to see people start adopting that one. So when you look at our virtual care portfolio, these are the specialties that we're actually using technology to connect a patient to a provider in 2 different locations. And so we're growing this based on demand. So there's no need for us to create something that there's not a shortage of or we don't have a need for. But every one of our hospitals or clinics needed this service. And now we deliver them over telemedicine. In remote monitoring, we're now managing that whole population on the right through remote monitoring. And that's actually delivering technology into the home and managing patients at home. And I'll show you a picture of that in a second. So in our telemedicine, this is nothing new. You've heard of this for decades now. But the problem was that most systems got all this expensive telemedicine equipment, carts, and they would sit in closets and maybe get used. No one could figure out how to pay for them, and as soon as things got tight or it was time to renew it or renew the support contract for the piece of equipment, somebody'd say, does anybody even use that? Let's just cancel that. And so there's a lot of starting and stopping of telemedicine programs. In the last 5 years, you've seen some of that change, and people are adopting it, like Kaiser's now moved 50% of their ambulatory visits to be available through telemedicine and not necessarily through in-person care. If you go look at a New York Presbyterian and some of those other ones, they're doing 1 million telehealth visits a year. Where I came from, at the University of Mississippi, we did 8,000 a month. So it was just about 1 million, and when I left there, we were continuing to grow that all over the state. So some very exciting pieces of our programs there that are making a real difference. For those that haven't seen a telemedicine program, you actually can do the full exam through this equipment. There's peripheral devices. You cannot smell or touch yet, but you can do everything else. I can look in eyes and throats. I can listen to heart and lungs. I can do everything through these devices and listen to it hundreds of miles away. And in matter of fact, in many cases, I can listen or look and see more detail because I can amplify or adjust lighting and see things better. So some exciting work there. In our digital clinic, we actually have an app that is our Good Health Digital Clinic, and it's a virtual provider office. And so now if you call for an appointment, like I talked about earlier, to see your dermatologist, and he says, and we have criteria, hey, I'll just see you at home. Don't go anywhere. Just click this button, and your appointment's at 2 o'clock tomorrow, and you just see them on your phone now. It changes things dramatically. Now it's not 2 to 4 hours off of work. It is literally in your workplace or at home, a simple connection to your provider. And so we've been expanding this and offering this for any of our physicians to use in their practice, but we also have an urgent care program as well, where we deliver these services to employers to be able to manage employee health as well. So we do it for our own employees in the Texas market and some other markets as well, and continuing to expand that. Insurance companies are adopting it and paying for it, so it's treated like an in-person visit from a reimbursement perspective in most states, and that continues to grow and improve, so some exciting work there. So here's the program I really wanted to talk to you a little bit more about, is our remote monitoring program. And so you can see a picture there of a box and some devices. So for our patients that have chronic disease, we expect them to get this diagnosis, and maybe, let's just assume on a good day, they get to go to 4 appointments a year for their diabetes and heart failure or whatever. And we expect them to be able to change their lifestyle and get healthier. The problem is that it's behavior changes and lifestyle changes that really take longer for that to be able to happen. And so by putting technology in the home and having a staff to be able to interact with the patient on a day-to-day basis, we're really changing behavior and we're changing outcomes. And so we have staff that is led by a nurse, and there's a whole care team, and the patient will take their vital signs at whatever time they want to. It's all Bluetooth, so they don't have to type in a number. But that information is uploaded, as well as a health survey. Did you take your medicine? How do you feel today? Those kind of questions. All of that information automatically uploads, and so my team on a dashboard can see, out of the 200 patients that they're monitoring at home, which ones do I actually need to video chat with, which ones do I need to get an appointment for, which ones need counseling or a phone call because maybe their blood pressure's up. So we're able to connect activities and behaviors to changes in blood pressure and vital signs too. So when all of a sudden it's Super Bowl Sunday and everybody on Monday's blood pressure's up, I can call them and say, what did you do yesterday? And their head will be tucked and they'll be mortified that we know. But then they start connecting, okay, what I ate and drank last night caused this. And so you can have some instant change in behaviors. And people always say, well, that's just too expensive. Who's going to pay for that? Well, I'll say there are changes in policy that allow for reimbursement of this as well. So that's one improvement. But second of all, if I can avoid one admission, one ER visit, it pays for this program. We typically leave patients on this for about 4 months, but there's graduation criteria. So they have to get better, and they get more and more independent in their ability to manage their own health. So that they can manage that on their own, and we can remove the technology. So there's 3 levels of the program, and I talked about graduation criteria. They may start on level 3 with that box and all the devices. Then they may move to an app-based solution where they're reporting symptoms and just checking in with us less frequently. And then they have, of course, the phone one where we slowly wean them off, and we're not cutting all ties with them immediately, but instead giving them the confidence that they've got this. And I'll tell you, the testimonies that we're hearing, not only from patients but their family members, are really amazing. So when there's a new diagnosis of your spouse with heart failure and you leave the hospital, I can assure you that spouse is sitting up all night, trying to check and see if everything's okay the whole time. They're terrified. And so when we hear those stories and the family members are literally in tears saying, I just know that you're watching them. It's like an extension of the hospital or the clinic. It's pretty amazing. The neat part about this is that we have an on-demand care team now. So it's basically like a mini clinical team at your beck and call. So there's a nurse assigned to these patients, But then they have all these other services that they can bolt on as they need. So if I'm the patient, Christy, and I have diabetes and heart failure, and I have needs around my diet or exercise or whatever questions around my medicines, the nurse will then notify the pharmacist, the dietitian, the social worker, the health promoter, whoever it is, and we all become a team working together, video chatting, texting, interacting as their little support group. And so we wrap around the patient and we bring those services in. They never have to come in to see us. We can do all this through video into the home. So we've added some new services as well because we think it's not about just medical care. It's not just behavioral health. It's also spiritual health and wellness as well. So we're adding in and layering in other services. We've just added a e-chaplain service program, but we actually added it first for the police in Wisconsin and Michigan. So they asked for 24-hour access to chaplain services because of just the unbelievable stress that they're under, whether it's from the profession and now the tension between the public and the police force, or it's events that they see, terrible things that they see. And so they asked for that, so now we have 24-hour access to chaplains for the police in those locations. So we've added that chaplain service into this program now so that our heart failure patients and others who are dealing with a lot of anxiety and stress and want to talk to somebody have those services as well. We're really trying to approach this very holistically, but it's an on-demand team that can help people whenever they need it. And because healthcare is not linear, it's not like you start here and you're gonna go to here. It's like chutes and ladders. You're doing fine, you get a new diagnosis, boom. You're better, you get it under control, you're in a car wreck, boom. So it's just constantly changing, and we have to be able to react like that, and we can if we coordinate and have better communication tools among the teams. Another program that I'll highlight here before I speak a little bit more to the value analysis of this is around what we've done in the surgical pathway. So, everybody in health systems, you'll hear them talk about, readmission penalties. You'll hear them talk about, we're responsible for a patient after a total joint replacement for 90 days, and we'll have penalties if we don't X, Y, or Z. If you back up and take that as maybe the trigger that makes you look at this differently, but think about it from your own experience with a surgery or just reality of patients have to come in, maybe they have knee pain, and that's what this story's about. This person has knee pain, they go in to see their doctor, they tell them they need to have surgery. Well, before you would just schedule surgery when you had vacation time. Now it's around, okay, is the person healthy enough to have the surgery so that we have the best outcome? So people are delaying surgeries until people are what we call optimized. So now we've flipped the optimization to be done through digital health. So once the surgeon gets the patient, they notify our Good Health Center that Christy Henderson's going to have a knee replacement. Then they come to me, and then I work on getting their blood pressure under control, their weight under control, their glucose, everything, health. They're prepared for pain management afterwards and what to expect in recovery. So it's education and it's health optimization. Then I notify the surgeon, Dr. Jones, Christy's ready for her surgery. She's met all the criteria. Then the surgery happens, they're handed back to us, and then we manage them after the surgery through rehab, through managing their new surgery and their comorbidities. So it's really an interesting journey where we realize that without our center, that experience is terrible because you're working with all these different groups from, PT, call centers, post-op appointments, clinic visits with your other specialist. And so if I now am owning that patient across the acute care, ambulatory, and home environment, I really can start piecing that all together to make more sense and quit duplicating tests and really make sure that patients get the services that they need. So, okay, so great. So you've pulled all these teams together, so is it making a difference? And so when we set in to do this in the first center in Texas, we set targets around, the obvious ones around call center metrics. Can we answer calls faster? Do we give better service? Do people show up for their appointments? But all of that's all great, but we really have to make sure we're improving health and lowering the cost of the system. So we started tracking things around readmission rates, show rates, and did we actually improve access to care? So let me show you just a few slides that may be hard to see, but you can see a downward trend. I think that's enough. But the heart failure patients that we started monitoring first with our remote monitoring program, across our system we had about a 26.4% readmission rate, meaning that 26% would get put back in the hospital within 30 days of leaving the hospital. After we started the remote monitoring program and started giving those kits to patients, managing them at home, we dropped it to below 3%. We've maintained it. We're right now at about a 2.47% readmission rate. That's unheard of across the country. And so we're going to keep doing this, and we're going to keep figuring out how much technology, how often do I need to interact with patients, until we really balance that. And you know what? It's different for every patient. That's what makes this hard. But we have a consistent program that allows for that scalability yet customization that makes it really effective. So in the last few minutes that I have, I want to show you kind of what that looks like, because there's a lot of thought into what does the center need to look like? Who needs to be in the center? If I'm going to move people from all over the organization to work together, let's be real strategic about that. And so if you'll look at this screen here, this actually shows you what teams sit by each other. We moved 25 different departments from across the organization into this one building. We have right now about 240 employees 24 hours a day in the Austin one. So it's a busy operation. But these teams next to each other, the adjacencies are extremely important. So before, if a telemetry tech was monitoring a patient and they had an arrhythmia that needed a code blue called, they would call the operator, and then the operator would activate a code blue, and neither knew if things got resolved. Now they're sitting next to each other. So they actually know, hey, it's this peace of mind, a closed loop. There's actually a safety net to where you can actually know. Before, you did your one little part of the work, but you never knew if it actually got taken care of. So this is where I put, access teams and care delivery teams and all the hospital services, all in very strategic location. Well, because now we're going to go national, we decided, well, how do we want to make this even better? And we need to expand this. So this is the second half that's being built. And what we're going to end up doing ultimately is have this one floor plan. It's about 60,000 square feet. One side is access and experience. So that's all your schedulers, your navigators, your operators, your nurse triage line, all of that are taking in calls that patients need services. And then the other half of the building is our care delivery side. So that's all your telemedicine, that's your remote monitoring techs. That is your physicians, your nurse practitioners, that care team that I showed you that was doing the home monitoring. They all sit in this other side of the building. All in the middle is an area for training and education, for community events, so that this becomes a whole center for access and care delivery. So we're super excited about phase 2 of this, and the Texas market, Indiana just opened as well, and then we'll replicate the same model in our third location to serve all of Ascension. So what I want to make sure and convey through all of this is that should be looked at from the lens of the experience of the patient. And so while we have departments and divisions, and we may have different tax ID numbers for certain parts of our organization, no patient, nor do we, if we are a patient, care about any of that. Why doesn't the person answering the phone know who I am and know that I was just up there? Why do they not know that I called about this same thing yesterday and I'm worried about my child? Why haven't they put this together? Well, we've just never thought about it like that, and these teams are all over working as hard as they can, well-intended, but all we have to do is pick up our head, look around, and coordinate and communicate better, and it's all sitting there. And so typically we look at this experience through a triggering event, sick care. But if we really do our job well, then we're moving to the next level where it's really about scientific wellness, and we're using data to really do things differently. So if you think about smart homes and pharmacogenetics and all the things that are out there that are data points that can help us do this differently, we can really begin to have a journey and an experience that's about health and wellness, not just sick care. And all while having that risk stratification and understanding different populations, and what I need is different than what you need, and adjusting that as you go through the whole continuum of care. So I'll end with this. So So we've made some radical changes. I don't know of another center that's pulled all these teams together in the country. So we're still in our 1 year mark will be November. So next year we'll have more information to tell you how good this is or how much more work we have to do. Our hope is that this model will be one that can be replicated across the country. But as things advance in technology and connectivity, we can radically change this and move faster. So if we think about one of our big, everything I just talked about requires some kind of connectivity. So if your facility doesn't have good Wi-Fi, or if a patient in their home doesn't have access to that broadband that they need to be able to connect, then we've got a dead end. We can't do it. So as that advances, there's some incredible advances in that, but as that improves, we will improve our communication, our ability to coordinate and deliver care through virtual means. People always tell me, well, this won't work. You can't do it because we don't have good whatever, Wi-Fi or whatever, or the patients won't accept it. They don't have a phone. There's a list. I have all the why nots. And then you're like, well, so what are you going to do about it then? If that's not an option, what are you going to do? But all I can come back with is that I started this in the Mississippi Delta, and there is no place poorer and with worse connectivity, and we did it. So it takes partnerships, it takes dedication and a relentless pursuit to make sure this works. They may not have a car, but I can assure you they have a phone, and we can figure out how to use that device. We just got to integrate it into our system of care and do it smarter. And so as we've started building more and more remote teams, I'll tell you what's been magnified is the need for us to have a good communication platform. And so that is an extension of the team, whether in the hospital or the clinic or the patients in the home. If I don't have an ability to communicate real time and in a smart way, then it's just data for the sake of data. And then it just sits somewhere and nobody does anything with it. So the integrated communication devices are changing everything. And how we integrate and interface with alarms and everything are game changers. The advances in technology are exciting. So all this data comes in, and we could have data overload. Even if I have a center that's looking at it independently, the ability to have machine learning and augmented intelligence, I always have artificial intelligence up there, and everyone cringes in the medical field. It's augmented. We need your brain too. So it's augmented intelligence. The ability to use that and have that analyzed to tell me how to make that actionable and to do something to fix it is even more important. Data for the sake of data doesn't matter. I don't want to know on your Fitbit that you walk 10,000 steps every single day. I want to know when something changed and there's something I need to intervene on. So that's going to be a game changer. Sensors and remote monitoring and smart homes. If I can remotely turn on my lights in my house, I can look in my refrigerator to see if I need eggs at the store. I can do whatever I want. I can also look into the homes of people to be able to help them when it comes to their health and wellness. So no one's really gotten into that yet. The digital clinics anywhere. A home clinic can be set up anywhere. There really isn't any need for people to come in unless they need lab or x-rays or whatever that has a procedure. And even that's going to change as more and more lab tests can be done on your phone. The logistics centers can drop anything to your house and you can do that test and they can pick it up and process it for you. I don't know what it looks like in 5 years, but I'll tell you it's not going to look like us all sitting in acute care hospitals. So it'll be exciting to be a part of that. The other piece of the puzzle that I have to bring up is that the pressures that all the healthcare systems have financially to do things differently and leaner is now coupled with incentives or penalties, however you want to look at it, to do things differently. And so it's like the electronic medical record. Until there was actually a meaningful use and reasons for us to do it, it was hard for us to make change. But now the policies and reimbursement and incentives are changing to where we're really going to be at risk and we're going to have to think differently. And so now if all those CPT codes and fees for a person sitting in our hospital go away and they just say, okay, you've got X dollars to take care of Christy, I bet I changed the entire system really quickly. So it's going to be exciting to see how these incentive payments and at-risk contracts really change how we do things. One of our ACOs in our area just came to us for the most underserved population and said, we really want to do this totally different. No rules, let's sit down and build the model differently. So we have a virtual primary care home for the patients, meaning that they start and all their care is in the virtual experience. And then they go in for in-person care when they need immunizations or physicals or something that we can't do through the technology, so that we can use the clinic space in a more appropriate manner. We were able to, through that mechanism, decrease some of our wait times for our specialists from 9 and 10 months down to 2 and 3 weeks, because we're using the clinic space differently. That's radically going to change our operations and our productivity. So it'll be fun to watch that. I know I'm out of time. I'm going to pause for questions, but I'm super excited about where we're going in healthcare. Thank you.
Eye-opening talk. Thank you, Dr. Henderson. Yeah. If anybody has any questions? Our roving mics are searching hungrily. Oh, I'm here.
Hi. I was wondering, what are some incentives for your employees to start remote healthcare rather than the traditional field of being in a hospital seeing patients in person?
Okay, so some people are not cut out for it. I'll start with that. And it's, we've got to change how we train the employees for healthcare of the future. And we've started partnering with different programs to do that. But let me answer your question in an honest way, in that those people didn't have a choice. We just moved them. But
tough but fair.
But I'll tell you what was so remarkable. I was worried. I still walk through there, and some of the people that work with me know I walk around going, there's people here, they came to work, this is awesome. But the energy in there is palpable, because they know that now we're looking at it differently, and for once they've been heard around why their job is so frustrating and fragmented. So when they were I don't know that it was so much the piece around the remote work, because some of these were really working in a hospital, but they were in an office and they were never interacting with patients anyway. They were on the phone. So they were really remote workers, but they were just happened to be in the hospital setting. So we moved them, and what they're most excited about is the adjacencies and team they get to work with now, because they're tired of getting hung up on, yelled at, and knowing that they're not delivering on what somebody needs. So that far outweighed me saying, you're now not going to work where you thought you were going to work. You're going to work in this new building that happens in some cases for people to be 45 minutes further away, and they're coming to work. It still kills me. So.
Yeah, over here.
Good morning.
Hi.
I found your presentation absolutely fascinating at the progress that's been made in such a short period of time. In many cases, you are dealing with a demographic that's not even supposed to know how to use email, and you're asking them to have Wi-Fi and communicate digitally and through video and do things to themselves to communicate. Is there any pushback there? Is that how do you overcome that?
So that's real, but I'll tell you that the number one barrier is us saying that. We think that, but when their option is no care, or their option is, I've got to take off from work for 4 hours, I mean, it's stressful. How many of you have canceled appointments because you just don't have time to go or didn't go? Every one of them, if you're in the line, if you didn't raise your hand. We all are well-intended, so then couple that with the financial challenges, transportation, childcare challenges, all of that, life is tough. So that benefit is there. Now, the other piece that we've always said is there are options here. So when I don't force them to not get their care in person, when they call in for appointment, we offer things. But now the physicians are also saying, hey, I'm glad you came in, everything looks great. Let's do a follow-up in 4 months, but hey, how do you feel about seeing me on this app? And we'll just check in, because all I'm gonna do is ask you how you feel. I really wanna see you and ask you these questions, but I hate for you to have to drive in and do X, Y, and Z. Those kind of interactions with the provider and the patient give them confidence in the system and understand it. And then we just have to train and we have to educate people. That's why we've added the education center in there as well for community events. But we did patient-family meetings with different groups around the city to ask them, what do you think about this? Do you like this? And for anybody that doesn't trust it, thinks it's big brotherish, whatever, they can come in person. This is just a tool, but it's usually us that think that they're not going to like it, and then they don't, but that's not the case.
Thanks a lot.
Yeah.
We're going to put a pin in the conversation right there, but once again, thank you so much.
Thank
Dr.
you.
Henderson.
Appreciate it. Thank you. Thank you. Oh.